Okay, so in this, when we go through the lectures of this program, you will have to bear with us for repeating some of the facts in different lectures, because, of course, when we talk about palliative care, so there is a lot of overlap in these subjects that we are going to have. So anyway, the fact that I want to tell you is that you're free to ask any question whenever you feel like, because let's make it a more interactive forum, and because otherwise you might start feeling boring as well. So anyway, now the issue that we come across in management of these palliative patients is that a lot of people believe that palliative care is offered only at the end of life. Okay, so it is commonly accepted in cancer patients, because cancer patients, when they are diagnosed by the cancer specialist, the oncologist, now earlier the lecture from Dr. Sujiva, you would have learned that. So when they're diagnosed of cancer, the oncologist will decide when the person is palliative. And it is not very hard, because the cancer is diagnosed and you can very well detect that the cancer patient is deteriorating, metastatic lesions are occurring. So it's not very hard, and it is accepted in the medical fraternity as well as in the community that cancer patients are for palliative care at the end, not only at the end when they are deteriorating. But then what about the non-cancer patients? So there are people who are actually unidentified, but who undergo suffering without properly being managed and without proper plans for palliative care. So the moment they are going to die, at the last minute, maybe just 5 to 6 hours before death, then everybody is concerned and everybody is trying to plan palliative care, and that is when the palliative care team gets a referral. So this is a fact. So 75% of individuals who die are never identified as potential beneficiaries of palliative care. That is for non-cancer. So patients with non-cancer chronic illness are particularly marginalized. Okay, so it's difficult to predict when patients will actually die. So who needs palliative care? So globally, 40 to 60% of all deaths need palliative care. So out of this, if you take the percentages, cardiovascular diseases account for 38.5% of these deaths. Cancer, 34. And then chronic respiratory diseases, 10.3. AIDS, diabetes, they take the other shares. Now, so you see others like CKD, chronic lung disease, rheumatoid arthritis, neurological dementia, congenital abdominal, drug-resistant tuberculosis are other causes. Now, you see, then in that case, you could see that, when you take the cancers, it's when the percentage of deaths are considered, it's not a major factor. But the other non-communicable diseases, plus the cardiovascular diseases, take the major proportion. So NCDs are estimated to account for 75% of total deaths. So in that case, we should be more aware of the non-cancer palliative care. So the challenges posed by conditions such as advanced respiratory disease. One is chronic obstructive airway disease, and the other one is end-stage heart failure, then end-stage renal failure, liver disease, neurological illnesses, dementia, and frailty, which occur mainly in the elderly, which occur actually in the elderly population, dementia and frailty. And when we talk about non-cancer, most of these we encounter in the elderly population. Okay, so when you recognize the need for palliative care in non-cancer patients, okay, people who are suffering long period of illness or disability. So when the disease is incurable. Now, if I ask the audience, okay, is diabetes mellitus a palliative disease? So, what would you say?
Yes.
Yeah, you could say yes, because it's a long-term illness. Okay. and it's incurable as well, isn't it? So, but then do we consider each and every person with diabetes to be palliative? No. So we need to find out when we call these people palliative. So one thing is to find diminished functioning, okay, such as recurrent admissions, exacerbations leading to diminished functional status, such as in COPD, end-stage heart failure. They start coming to hospital repeatedly, and then they undergo functional deterioration with loss of muscle mass, loss of mobility, okay, and also consider the potential of having exacerbations leading to death. So one of these exacerbations, this person is going to die. Now, in our hospitals, we see lots of people coming and getting admitted and then going home after 1 or 2 days. We say they are chronic people. But most of the time, we never take any effort to tell them, or the relations, the patient and the relations, call them and then tell them, okay, now this person has been coming recurrently to the hospital. And most of the time we are able to manage and we are sending this person home. But we can see, okay, if it is heart failure patient, we can see our echocardiograms, our tests show that this person is having very compromised uh, ventricular function with an ejection fraction of 25%. And this person is now weak, difficult to mobilize, okay? So functionally impaired. So therefore, we think that any moment, next time if this person gets admitted, the person is going to get severe disease and may end up with death. So therefore, we need to now talk about management of the patient in such an exacerbation if the patient goes into cardiac arrest. So are we going to do a resuscitation or not? Are we going to put into the ICU and intubate? So all these you have to pick up some time early in the disease. Now this surprise question. So would you be surprised if your patient would die within 6 months? This is sometimes some literature, they are asking 6 months. But then we generally take the 12-month period. So now if I ask you, when you ask a question, will you be surprised to see this person alive in 12 months? Okay. If the answer is yes, that means the patient is going to die within this year. What does that mean to you as a doctor? Your idea? If you are surprised to see the patient after 12-month period, what does that mean?
The question is not much clear.
Now, when there is a person that you are treating, okay, and this person is having chronic obstructive airway disease, okay, and you have been treating, and you ask this question from yourself, will I be surprised to see this patient after 12 months? That is, after 1 year, will I see this patient coming back to me? And if you think, no, I don't think this person is going to live beyond 12 months. So I will be surprised if this person turns out after 12 months. You understand?
Yes.
You make your judgment. Then what does that mean? Does it mean that the person is a palliative care patient? Does it mean that the patient is in end of life period or terminal? There are 3 categories that you need to understand.
Palliative care patient.
Okay, how many say it's end of life? Who are the people? Are there any people? I can't see the audience, so you can. Any people who are saying end of life? You can talk. Okay, so my question is this. Now, this is the problem among many doctors when we come across palliative care. Now, it is very difficult, as I said, to decide when you decide a person is going to need palliative care. So now, in a cancer patient, this decision is taken by the cancer specialist. In the case of non-cancer, this decision is taken by the treating physician. Decision is taken by the treating physician. So if it is a cardiologist, the cardiologist can take the decision in regarding a patient with heart failure. If it is the physician who is in charge of the patient can decide. Now, the fact is, there are the categories of patients. Now, if a patient in your hand has the likelihood of dying within days or maximum few weeks, but not more, not in months, okay? Hours, days, or maximum about 1 week. That kind of patient, what do you call? Is it end of life, terminal, or palliative? Into the broad spectrum of palliative, yes, they are all included. But if a person is going to die within hours, minutes to hours to days, actually, weeks is not a possibility. Minutes to hours to days, that is a terminal stage. You get my point? If you are surprised to see a person after 12 months, that means the person has reached end of life care situation. Okay. Palliative starts even much before that. May even start 2 years before you anticipate all of these problems. Do you understand what I'm stressing or trying to emphasize? You can ask questions, then we can make things clearer. Can you understand? I want some responses.
Yes.
So, okay. So, what is end of life care? Period.
Hours to days. Hours to day. Hours
No,
to
that is terminal care. Hours to minutes, minutes to hours to days is terminal care. That is a time when you really have to put the patient into a comfort care pathway, just manage the symptomatic problems and make sure that the patient dies with dignity. Okay?
The time of death.
So you got it. So then other one is end of life. End of life period is actually 12-month period. If you decide this person is not going to live beyond 12 months, that is end of life. So end of life, terminal, all include into palliative. But then palliative starts very much earlier than both of these. It's very important to understand this because a lot of people, whatever, how much lectures there are, how much literature there is, the tendency to diagnose a palliative patient in a common medical ward happens to be during the terminal stage. Because when the patient is dying, only everybody will rush and then think of God. So by the time the palliative team arrives at the site, the patient is about to die, gasping for breath. So this is, that's why I spent a little time to explain this phenomenon very clearly to all of you. So when should palliative care start? So it's a difficult stage. So applicable early in the course of life-limiting illness, no longer amenable to cure. So when do you recognize the need for palliative care in non-cancer patients? So this is an example that is given. Danger, thin ice. Okay. So this is a picture of a lake which has frozen. You know the danger of walking on a frozen lake. So when you walk, there is a chance of the ice breaking and falling into the lake and dying. So, but you don't know when it will happen. Suddenly it can happen. This is an example we can give for non-cancer illnesses. One can keep on walking, but there is a chance of dying at one point. In real life, they might cross the lake, but in a non-cancer palliative patient, no one will cross this lake. Everyone will die at some point. But when this person is going to die is a very difficult situation. It's an uncertainty in non-cancer patients. And that's why lots of guidelines have evolved to explain this. It's also like hanging from a cliff on a branch. So when this branch will break off, we don't know. Or on the edge of a cliff, balancing, one point, the person is going to fall and die. So we need to identify that time. So throughout the lectures, you will see these disease trajectories. So this is from the gold standard framework, end of life care guidelines. So you can see this, the top one is about cancer, which you would have seen in the previous lecture. So they go on having a good functional status until at one point there is a deterioration. Okay. So therefore, death can be anticipated because you know when the person is going to deteriorate. Or this is at this point, you know when the death is going to happen. So an example given is this is a 69-year-old woman with cancer of the lung and known liver secondaries with increasing breathlessness, fatigue, decreasing mobility, concern about other matters, likely rapid decline. Okay. So then you can see that it's predictable. Death is predictable. Okay. Then we take another set of diseases, the non-cancers, right? Now this is where the person's functional status fluctuates and at one point death occurs. This is what I said. At one of these exacerbations, the patient is going to die. Good examples are heart failure and COPD. So Mr. B, an 84-year-old man with heart failure and increasing breathlessness, who finds activity increasingly difficult. So functional capacity going down. He had 2 recent crisis hospital admissions, so recurrent admissions, worried about further admissions and coping alone in future, decreasing recovery and likely erratic decline. So that's about organ failure. Okay. The first one, cancer. Then the second, frailty and comorbidity, dementia. Person with many diseases occurring together, or dementia or frailty. Frailty is a concept defined in geriatric medicine. It's a geriatric syndrome where a person undergoes a functional decline and loses a resilience and becomes vulnerable. And then because of the increased vulnerability, the person can undergo adverse outcomes due to even minor stimulations in the environment. So that is frailty. So person with frailty, dementia, this is the cause. They start when with the disease, anyway, they have a very poor functional status and then it goes on at a poor functional status until at one time the person dies. But here, again here, it becomes at a certain stage, death becomes predictable when the functional decline is really, really serious. So Mrs. C, a 91-year-old lady, so elderly person with COPD, heart failure, osteoarthritis, and increasing signs of multimorbidity and dementia, who lives in a care home. Following a fall, she grows less active, eats less, becomes easily confused, and has repeated infections. She appears to be skating on thin ice. So this is what we said. Difficult to predict, but likely slow decline. So at one point, they are going on this thin ice. At one point, the person is going to crash. So, so these are the disease trajectories. So to make clear, mostly cancer, short period of evident decline, and then mostly heart failure and COPD at one point death, and then mostly dementia and frailty, ending up in death with already a poor functional status. There's a progressive decline from already a poor functional capacity. So you can see that it is not as easy to define the palliative care stage as well as the time of death in this sweeper. So the palliative care model, so you have gone, this is why I said there are a lot of repetition. Anyway, therapy to modify disease will reduce as with time, and therapy to relieve suffering and improve quality of life will be taking a major proportion. So palliative care will start early when the focus of care, when we decide that therapy to modify disease, the place of treatment in modifying disease is low and it's going to be incurable, and therefore we must start thinking about palliative care. Okay, so when the exacerbations are occurring, when we think that the person needs support, okay, then we start. So palliative care, there's no defined time when we start, but that is the idea. You can see here, end of life care is here. Okay, this is the last 12 months. Okay, and then minutes to hours to days will be the last time just before death. That will be the terminal care. Okay, and even after that, bereavement care, Dr. Sujeev also explained to you. So instituting early palliative care benefits for patients, provide relief from pain and other distressing symptoms, integrate psychological and spiritual aspects of patient care, affirm life, regard dying as a normal process, neither to hasten nor postpone. So it's very important because we must not be unprepared. The patient and the family need to be prepared in the event of a palliative disease. So there's no point if we are all unprepared and then looking for answers and looking for explanations when the patient is just dying in the terminal stage. So we often do not recognize the terminal. Maybe the most challenging aspect of care. Patient and family not prepared, needs have not been assessed, supports not offered, goals of care not adopted. So goal of care, now you see a lot of patients coming to the hospital. Now they come and say, okay, this is a 91-year-old patient, now having exacerbation of heart failure, and they come and say, doctor, we need you to do everything. Okay, put the patient to the intensive care, please, and we are ready for ventilation, and we want to save our mother. So why does this happen? Because they have not been offered any advice on the advanced care. And nobody has talked to them about what's going to happen in the event of another exacerbation. So needs have not been assessed. In palliative care, actually, in life, of course, we have short-term goals and long-term goals. But in palliative care, probably we are talking about mainly, especially at the end of life care, there are short-term goals. But in palliative care, you may have some long-term goals because the person may be living for some time, So goals of care have to be decided with the patient and the family. And then having inappropriate goals would put everybody in distress, the patient, family, and the staff as the doctors, nurses, everybody. So identify people for integrated palliative care. When should palliative care start? Okay. So person who is living well with long-term conditions, then we don't have to worry about that. Okay, they're stable. Then they become unstable and start deteriorating. When they're having deteriorating health, yes, then we have to. So this deteriorating health area is the time when we need to initiate palliative care. Okay, and then if we initiate palliative care at this stage, then the dying phase would not be that uncomfortable because the patient, family, everybody will anticipate death. So identifying people for integrated palliative care, there are different guidelines, as I told you. SPICT is a guideline from the NHS. So clinical indicators of major advanced conditions like cancer, dementia, organ failure, heart, lung, kidney, liver, neurological, other conditions with limited reversibility. So there are guidelines given. Okay. So this is the supportive and palliative care indicators tool, SPICT, by the NHS. Now, if you see this says SPICT is used to help identify people whose health is deteriorating, assess them for unmet supportive and palliative care needs. Now, these are guidelines. So, but the decisions, we need guidelines, but the decisions are not strictly made on the guideline. So, we all need to understand that there are such guidelines and go through them and understand the concept behind it. Okay. Now, there are what are called general indicators of poor or deteriorating health. Now, let's read through the SPICT guideline. They talk about unplanned hospital admissions. Performance status is poor or deteriorating with limited reversibility. Example, the person stays in bed or in a chair for more than half the day. Depends on others for care due to increasing physical and or mental health problems. The person's carer needs more help and support. Carer also needs support. As progressive weight loss, remains underweight, low muscle mass, persistent symptoms despite optimal treatment of underlying conditions. The person or family asks for palliative care, chooses to reduce, stop, or not have treatment, or wishes to focus on quality of life. So these are indicators for palliative care. Now, for each disease, so I will not go through every one. So other diseases also they have given. Now, for example, kidney disease, stage 4 or 5 chronic kidney disease, EGFR less than 30 ml with deteriorating health. Okay. Kidney failure complicating other life-limiting conditions or treatment. Stopping or not starting dialysis. Those are indications. If you take heart vascular disease, heart failure, or extensive untreatable coronary artery disease with breathlessness or chest pain at rest on minimal effort, severe inoperable peripheral vascular disease. So for each disease, they have given specific clinical indicators as well. So the other prognostic indicator is the gold standard framework in end-of-life care. Here, most of these indicators actually have aimed at end of life. So that is the 12 month. So this surprise question is, would you be surprised the person were to die next months, weeks, or days? Okay. So that is the surprise question is aimed at end of life. So if the answer is no, that means the patient is likely to die, then you go for the gold standard framework process. Okay. Which includes identifying the patient as a palliative care patient and including them in the register, discuss at their team meetings, discuss with this patient carers, assess needs and likely support, record advanced care planning discussions, and plan and provide proactive care to improve coordination communication. So good symptomatic management and communication, all of these are started as a palliative care, as an end of life care process actually for this. So this is called the gold standard framework. Okay. So ask a surprise question. If you don't know whether this person is going to die within the next months, then you can find out do they have general indicators of decline. So that also will decide. Like in the SPICT guideline, here the general indicators of decline will give an idea whether this person belongs to palliative or not. If that is also answered, then you can go for specific clinical indicators of illness, like what I've shown in heart disease and advanced respiratory diseases. You can go for that. So if they have either of these, then they go into a process where they are managed with advanced care planning and planning for the end of life situation. So if you think this person is going to live, but with a terminal illness, you can assess regularly. So actually, palliation can start in these people as well, even though they are not going to die in 12 months. So palliative care is given, assessed regularly, and decide when they go into this end of life care path. So it's a surprise question. For patients with advanced disease of progressive life-limiting condition, would you be surprised if the patient would die in next few months, weeks, days? This is the question that we have asked. Okay. So this is not an easy question. So you have to consider not only the physical factors, but the social and psychological factors as well. So even if you think that this patient is going to live beyond 12 months, still you need to consider improving the patient's quality of life and prepare and anticipate a decline and manage this patient. Okay. Okay. So a few facts about these general indicators given in the gold standard framework. So I'll just go through them. Are there general indicators of decline and increasing needs? So one thing is decreasing activity. So for that, you need to assess the functional performance. Okay. There are different ways of doing that. One thing is the Barthel index. Okay. And then there are other like the Karnoff's performance scale. And then there is ECOG scale. So there are different. But for this, the activities of daily living, Barthel score is one good indicator. Comorbidity is regarded as the biggest predictive indicator of mortality and morbidity. General physical decline, advanced disease, unstable deteriorating complex symptom burden, decreasing response to treatments, decreasing reversibility. So when you start thinking this person, however much we treat, the condition is not reversing but decreasing every time the person comes. So for example, good example is COPD. Every time the person comes, we treat, then the person goes home, but by the time the person goes home, he has had further decline in the functional status. So not improving, but reduction from the pre-morbid state. There's a stepwise deterioration in the health. Okay. So choice of no further active. There are no other options available now. Progressive weight loss, more than 10% in past 6 months. Repeated unplanned crisis admissions. Person sent home, returns within 2 days, failed discharge. So that is not actually a failed discharge. That is actually the situation of the patient. Okay, sentinel event, example, serious fall, bereavement, transfer to nursing. Suddenly the person deteriorates, and then comes the fall, and then immobility, pneumonia. So this is a situation that we are going to consider. This patient is not going to live long, and we must address these situations. So, but these general indicators are actually for end of life. And serum albumin is another indicator. When it is very low, that is also bad prognostic factor. So the functional assessment, Barthel index, basic activity of daily living. And as I told you, there are other tests like the pulse screening assessment, Karnofsky, and the ECOG. So these are some of the examples. Okay. So furthermore, gold standards framework, they consider end of life indicators for cancer, chronic obstructive aortic disease, heart disease as well. So I won't go through everything. This is given even in the book that we have given you, the palliative care guidebook. So that is available as an online book, as well as you can read the book as a hard copy. So renal disease, neurological disease, motor neuron disease, advanced neurological, Parkinson disease, multiple sclerosis. All of these diseases, we have indicators. Okay, end of life indicators. And then for frailty. For example, a frailty, I told you they are already having a reduced functional capacity. So individuals who present with multiple comorbidities with significant impairments in day-to-day living with deteriorating functional score, example, performance test, Barthel, ECOG, Karnofsky scale, combination of at least three of the following symptoms. If they have weakness, slow walking speed, significant weight loss, exhaustion, low physical activity, depression. So if they have at least three of the following, then we consider them as palliative, because each and every frail person is not palliative. Or in this case, actually, it's end of life. So each and every frail person is not having end of life. Each and every frail person is not expected to die within 12 months. But if they are having these factors, then they are considered as end of life um, treatment needing patients. Similarly, for dementia, so there are many underlying conditions which may lead to degree of dementia, and these should be taken into account. Triggers to consider that indicate that someone is entering a later stage are unable to walk without assistance, urinary and fecal incontinence, and no consistent meaningful conversation, unable to active of daily living, Barthel score less than 3, plus any of the following like weight loss, urinary tract infections, severe pressure sores, recurrent fever, reduced oral intake, aspiration. Now it's very important to know this, because now dementia is actually with time we have seen more and more patients coming to us for treatment of dementia, because our population is aging. Now 1 in 4 of us will be over 60 years of age in 2040. So we are having a rapidly aging population. So therefore, people are living now. For a female, the life expectancy is around 80, even more than that. So we are going to see more and more people living to 85, 90, 95. So when they grow old, there's a higher chance of these people ending up with Alzheimer's disease and vascular dementia. So we are going to see more and more people with dementia. So therefore, we need to decide when and what to do in these patients who are having deteriorating illnesses. Now, good example is if this person, according to the gold standard framework, qualifies to be an end of life patient, and now this patient is approaching death at that time. For example, this patient has weight loss, recurrent aspiration pneumonia, reduced oral. Sometimes people come and ask to put NG feeds, PEG feeds. So then you have to decide, okay, is there a prognostic benefit of doing these things? So that will be decided by going through these factors. Even in a legal situation, if they are coming back and saying you didn't insert NG tube, that is why our patient died due to starvation. So if these facts are considered, then you can point out, okay, this person has now reached end of life. And by doing these measures, we are not going to make life better for these patients. In fact, we might make it worse according to the evidence that is given. So therefore, you need to make decisions. So you need to know these facts and refer to these when necessary. Okay. So now coming back to our non-cancer palliative care, now the symptoms of palliative, non-cancer palliative are actually the same as for cancer. So for example, if you take physical, pain, breathlessness, anorexia, immobility, constipation, all these are symptoms that you see in cancer as well. Psychological, depression, fear, anxiety, uncertainty, guilt. Then religious, spiritual, religious. Now, what do you mean by spirituality? If I ask the audience now to break the silence, what do you mean by spirituality? It might mean different things to each and every person. Hmm? Yeah, just to stimulate some thoughts. Yeah, just tell me. There is no definition. I want to know what you feel about spirituality. Hmm? No contributions.
If
Huh?
believe
Yeah.
that
Sorry. Didn't hear. Sorry, it's not clear.
believes
Yeah. Huh? Can you speak up?
believes about the life,
Believes. Okay. Believes meaning about what?
about the life.
Believes about life. Hmm?
So religious belief.
Religious. Okay. Does it need to be religious? Hmm? There are non-religious people, no?
Yeah.
People who never sight a temple, never go to the church or to the kovil. Huh? What about them? Hmm? Huh? Are they non-spiritual or a-spiritual? Huh? Hmm?
Both are there, non-religious as well as the religious, the spiritual.
Yeah, whether they are religious or non-religious. Now, this is a very deep area. Now, you and I may have different ideas about what will happen after death. I don't know what will happen to me after death. Buddhist person may believe that if they have done merit, they will end up in nirvana. And therefore, that is why we all wish people to attain supreme bliss of nirvana, nibbana. And then a Christian person might have different idea. And some person might think we become just soil after death, and there is the end. Nothing, no afterlife. Okay. So whatever we believe, now because this death is a issue, so people will have different beliefs, ideas about life, and some will think that they would have lived a good life and then done good to people, and that then good will come to them after death. So the fact is, nobody returns after death to tell us the experience. And that is why it's so uncertain to all of us. Our loved ones die and they leave us, but they don't return and tell us, even in our dreams, what they went through at the time of death. At some point of life, we will also go through that. We will also die. If you think far ahead, someday I and I will die. We don't know how we will die. But we all wish that we die without pain and without much of distress. Okay. So, and at the end of life, the spirituality may, increase, because we may not be thinking about these things when you are so busy in life. But when you have disease and we have nothing else to do but confined to a bed, then we may start thinking. So then this spirituality has to be respected and supported. by us. So we cannot inculcate our beliefs and say, no, no, you are, this is how this ends up, and you will be reborn, and we will, these are things that happen. That is spirituality of myself or somebody else's. So understanding the spirituality of the person and address it. Okay. So this why me question. Why me? Why this happened to me? When I have done so much of good in life, why did this happen to me? So some people will say it's due to karma. And then so we are not going to contradict their opinions, even if we believe otherwise. So it's very important. The meaning of life, the meaning of death, and what's going to happen. These are all spiritualities we have to understand, and these are also part of the symptom analogy. So these are also symptoms. So you may have to explore these when you are doing palliative care. Not only ask about the aches and pains, but about the spiritual needs, about what you think is going to happen, what you believe in life. So when you may have to spend some time with the person and go through this, which is not done in other aspects of care. So social we do in our history taking, but not spiritual in our history taking usually. But social, yes, about the employment, role change. So, what were you before the illness took charge? How did you cope up? And what are the issues that you're going to face in the home, in the community? So, all these, okay, the problems with loneliness, fear of being a burden, all of these factors are going to be important as social factors, social symptoms. So we have to, these are also symptoms, okay? We need to find out whether it's a cancer or non-cancer. These are symptoms that we need to explore in a person undergoing palliative care. So I spend some time on this because those are not addressed usually in our symptom analogy, okay? Now, speaking of symptoms, there are top 10 symptoms of concurrent palliative care. This is a study. So, in that, they have talked about the most common prominent symptom being pain, and then dyspnea, constipation, nausea, vomiting, anorexia, weakness, lethargy, lack of mobility, and other general problems and weight loss. Now, all of these symptoms, the idea of this palliative care program is to address these and by different specialists. So dyspnea will be addressed by Dr. Ravini. So respiratory physician like that. I mean, neurological problems by Dr. Gamin Patana. So different specialists will address the gastroenterology symptoms by another consultant, Dr. Nilesh. So we have different specialists coming in to give lectures. So I will not be going into each and every symptom and also management of all these non-cancer symptoms in this lecture. This will be only an introduction as a guide. Okay. So let's talk about end-stage heart failure. Now we'll take some diseases just to give you an overview. Okay, so the challenges are optimizing symptom relief, maximize medications used in heart failure, more emphasis given to medicines like opioids. Okay, so morphine takes a major role in management of heart failure rather than the prognostically beneficial drugs like ACE inhibitors, spironolactone, and so on. So end-stage heart failure, up to 1 to 2% of the adult population will get this. And it increases with age, more than 10% over the age of 70. So more you live, more chances of our organs undergoing deterioration and failure. So there are higher chance of developing heart failure if you live beyond 70 years, even if you don't have much of risk factors. So mortality is higher than for many cancers. With a 60% annual mortality for stage D heart failure. So in a terminal heart failure, the end-stage heart failure, the mortality is much more than for many of the cancers. So therefore, you need to address them as palliative. So end-stage heart failure versus cancer, symptom similarities. If you take, I mean, these are all symptoms that you come across. Now, dyspnea, cachexia, nausea, weight loss, constipation, poor mobility, they are all common. Specific to probably cardiac failure could be giddiness, postural hypertension, cough, may be common to some cancers as well. So insomnia can occur in both, confusion, delirium in both, anxiety in both conditions, depression in both conditions. Polypharmacy more so with the end-stage heart failure, unnecessary, inappropriate polypharmacy. There are patients who are having end-stage heart failure given medicines according to the evidence-based guidelines. They are on diuretics, they are on ACE inhibitors, then drugs like empagliflozin, SGLT2 inhibitors, okay, and then other medicines, calcium channel blockers, spironolactone. So it's a big list of medicines to optimize treatment. And these patients' heart failure is now in the end stage. Blood pressure is 90/60 with all the load of prognosticating medicines. Okay, patient can hardly walk, is falling down with dizziness, postural hypotension. So that this kind of patients, you have to optimize the medicines, meaning you have to cut down on all of these unnecessary evidence, so-called evidence-based medicine, because this evidence is probably based on the number needed to treat. You need to treat large number of patients to get a benefit in few patients. If you go through this research. The other thing is, none of these trials have involved severely frail patients or multimorbidity patients or very elderly patients or patients with end-stage disease. So therefore, this evidence is not applicable to many of these patients. Okay. So it's very important. Be mindful of this fact. So even if you come across a patient who has been treated by some cardiologist based on evidence, think about the patient as a whole and then try to cut down the unnecessary medicines. It's called inappropriate polypharmacy. So if appropriate polypharmacy may be there, because in certain heart conditions, you need to give a certain number of medicines. Also, the fear of the future, jaundice, all these are common in both these diseases. So end-stage heart failure symptom differences, edema more dominant in heart failure. And also the difficulty predicting life expectancy. And this is what I told you. These exacerbations occurring, at one point patient dying, it's like walking on thin ice, difficulty predicting life expectancy. So there are the differences in heart failure. So challenges are inadequate address of patient symptoms and failure to seek or heed patients' wishes. So you have to discuss about the short-term goals of these patients, what they want to do in life before suddenly an unexpected exacerbation occurs and patient dies due to another infarction and heart failure. So the prognostic markers, which we discussed in different like the SPICT or the gold standard framework. So these are the prognostic markers that you need to consider in palliation. So recent cardiac hospitalization, serum creatinine more than 120, systolic blood pressure less than 100, pulse rate more than 100, decreased left ventricular ejection fraction less than 30%, treatment-resistant ventricular arrhythmias, anemia, hyponatremia, other factors, other contributing factors, anemia, hyponatremia, cachexia, reduced functional capacity, and comorbidities. So in these are poor prognostic markers. So end-stage heart failure, we need to have symptomatic management of the dyspnea. So there are non-pharmaceutical measures such as reassurance, repositioning. Now, very important. Sometimes merely positioning the patient may relieve the dyspnea of a person. Adjusting the angle of the bed, okay, would be very important. An explanation. Sometimes symptoms may mean different things to a person. So the dyspnea may mean just the exacerbation of heart failure to me as a doctor, but to the patient, it may be a feature of impending death. Okay, or person may be thinking that there may be some other pathology occurring in the heart. We never know what the people are thinking. So we need to explain why these symptoms are occurring. So there are pharmaceutical measures like diuretics, vasodilators, oxygen, opioids, regular immediate release morphine or parenteral morphine if actually distressed. So you can start something like 2.5 to 5 milligrams, 6 hourly, and then go on. In every LDL, you can go for a 8 hourly dosing or subcut morphine. So for edema, do diuretics, fluid restriction, mild salt restriction, aim for weight loss of 0.5 to 1 kilogram per day. And combination treatment like metolazone and furosemide can be offered. So general advice, assess appropriateness of home, establish need for oxygen, monitor fluid status, immediate release morphine for dyspnea. Haloperidol can be given for agitation and also providing emergency contacts. So let's go through this case. Time for you to read. Okay. Now tell me what are the factors that you think this person is. Firstly, tell me whether you think this person needs palliative care or not.
Palliative.
Yeah, it's a palliative patient. Why? Some reasons.
Yeah. So full ejection fraction is 15 to 20%.
15 to 20%. Yes.
So having dilated cardiomyopathy with
Cardiomyopathy with ejection fraction 15 to 20. Yeah.
So the cardiologist decided to go into conservative management.
Yeah. So, okay. So the treating physician, the cardiologist has decided that the person is palliative. So there is no doubt now. So the doctor, this is very good. If the consultant makes a decision and writes on the ticket or the diagnosis card, then it is a very good guide for the other doctors who are going to follow up. So very good that is done. Yeah. What other factors you would consider for palliation?
You have to talk with the patient.
No. From this, from the information you have got, tell me what other factors suggest this person is for palliation. Ejection fraction, cardiologist statement.
Dilated cardiomyopathy, ejection fraction.
That's already told.
Okay.
New ones, new facts.
Incontinence in the constipation.
Incontinence.
Crepitations in both lungs.
Crepitation in both lungs is not a factor, no? That is not a deciding factor. Anybody with heart failure can have crepitations.
Shortness of breath.
Shortness of breath also everybody will have. But here there is something told here. Shortness of breath is not the only thing. On mild to mild exertion, then the person qualifies to NYHA class. Okay. That, of course, leads to you to thinking whether this patient is for palliation. Okay. What else?
The patient is having fever and so might get exacerbation of symptoms.
That is the other one. Patient has recurrent hospital admissions with exacerbations. So all of these indicate that the person is palliative. So let's see. On further questioning, revealed that he lived with his wife, who was very supportive but very frail. Okay. He was a retired school principal. After retirement, he had been very active person in the village, giving leadership to various social and religious activities with the functional disability. Now, the other one, here, if you noticed, it is said his mobility was further limited due to pain in hip joint. So that's also another factor, reduced mobility. Okay. Pain in his hip, which at times disturbs his sleep. He was reluctant to go to toilet as it is a squatting pan at home, and it is exacerbated his pain and felt him very tired after passing stools. So investigations, X-ray, fecal loading, chest X-ray, cardiomegaly with acute heart failure, with right middle and lower zone inflammation. Now the patient has come with infection, with exacerbation of heart failure, and that's why the core script is on one side. Neutrophil leukocytes with elevated CR. So as expected, this is another exacerbation. Okay, serum creatinine is 1.5, so that's high. So that's another poor prognosticator, isn't it? Renal impairment with heart failure. UFR showed 56, that's expected, could be an infection or could be normal. So is this patient palliative? Okay. Advanced cardiac failure with recurrent hospital admissions, worsening heart failure, shortness of breath, even in between admissions. Okay. So therefore, this patient is palliative. So end-stage heart failure, the American Heart Association says stage D of ABCD classification, patients with refractory heart failure requiring advanced intervention is biventricular pacemaker, left ventricular device transplant. So this patient is like that, stage D. Then the class 3 of New York Heart Association also, it's NYHA classification. Class 3 symptoms of heart failure, minimal exertion. And class 4 symptoms of heart failure at rest. So these are the important factors to consider in deciding whether this patient is palliative. So if you go back to our, so these were the prognostic markers we gave. So ejection fraction, okay, and then cachexia, reduced functional capacity, comorbidities, which are present in the recent cardiac hospital or recurrent cardiac hospitalization. Okay. Okay. So that's a case for you to understand the decision of palliation in non-cancer patient. Right. So a few guidelines for communication with patients who are having heart failure regarding prognosis and plan of care. So assessment, ask the patient what he or she understands about his heart, exploring the understanding. Okay. Prognosis. Be conscious that prognostic uncertainty is no excuse for a failure to communicate about the implications of advanced heart disease. It is a fact that you don't know that the person is going to die, but it is, even though uncertain, we know that at one point this is going to happen. So we have to discuss with the patient in regard to advanced care. Preparation. Prepare the patients emotionally for what is to be expected. Provide approximate time estimates. Example, months or years. Talk about some likely scenario. So here, but it's going to be years, we don't know. If the surprise question is, no, you are not going to see this patient living beyond 12 months, then that means it's end of life and you need to talk about this situation. So guidelines for communication with patients about heart failure, preferences. Discuss healthcare proxy goals if the patient is permanently brain injured, cardiopulmonary resuscitation, ventilators, all of these. Discuss deactivation of ICDs. Now, this is another issue. Now, there are sometimes ICDs implanted. And then when you decide it's a person is for palliative care, you need to deactivate. Sometimes it may be a very difficult process. You may have to talk to the manufacturer or the person, people who have developed, and then get the guideline and deactivate. Now, this happened to one of my patients, where this patient had a ICD with a defibrillator in situ, and this patient had a CKD and was on dialysis. So I had a discussion with the patient who was conscious and very much alert and having a good, clear consciousness. The patient's renal functions were deteriorating, but the person's heart ejection fraction was low, around 25%, but person was functioning. But his life extension dependent on the repeated dialysis. So he had a discussion with me and as well as the family, and decided that he does not need any more dialysis. So he decided against dialysis. And we clearly documented on the BHT with the consent of the patient and the family that this patient has consented to remove the opted not to have dialysis and the vascat to be removed. And then also for the ICD to decided that the ICD should be disconnected. So we contacted the cardiologist and we got the ICD implantation that company, and then we got the guy, the advice, and then deactivated the ICD. Okay, so the defibrillator was now deactivated, and person was quite good. And then the person opted to go for just comfort care, this symptomatic management, and then this person was taken to the theater for removal of the vascat. And during the removal of the vascat, this happened in a private hospital, the person had a cardiac arrest. Now everything documented on the BHT, but the team continued with CPR and everything was done to this patient. Cardiac massage, defibrillation, and all the works were done. And after which the patient died. So this is why we need end of life care guidelines. And I was the chairperson of the palliative and end of life care task force. And then I'm one of the people who guided the task force in developing the end of life care guidelines. So ultimately now we have got the end of life care guidelines. Still, it's not a very legal document, but now that this is there in practice, so the health professionals can make use of that. So I think it is also provided to you. The link for the end of life care guideline will be provided to each and every one of you. Now the explanation, then we asked for actually the relations wanted to sue the hospital for doing the CPR, because everything was documented and we had decided that the patient is not policing. But then the explanation given by the hospital was that each and every person who has a cardiac arrest needs to be resuscitated according to the Sri Lankan law, and therefore they will do it. And there is no question about it. and they are not going to can get take consent from the relations. So legally, at that time or even now, if you resuscitate a person by force, you can't be found guilty. But if you don't resuscitate and the family complains, you can be found guilty still. But now with the end of life care guidelines, we can say, okay, this is a guideline that we have developed um, by the SLMA task force, and now it has been accepted by the colleges, so by the Ministry of Health in Sri Lanka. So therefore, there is a set of guidelines where you could discuss with the family and the patient and then decide that the person is not for resuscitation. So in future, these will become common law. At the moment, it is not common law, but in future, with legislative processes occurring following the citation of these guidelines in the future, we would see these guidelines becoming legalized, so that then at that point of time, the doctors will not face a problem as well as the patients and the relation. So you can see how decision making can be challenging at certain times when you don't have clear cut plans. Even when you have clear cut plans, even when you have advanced directives and advanced care planning, if legislation or guidelines are not in place in a country, then there can be problem. Okay. So planning for the worst suggests getting financial and emotional affairs in order, help to mobilize communities. The last point in this communication of this heart failure patients. Okay, so as I told you, now there's no break between the two lectures. Now I've already gone beyond my 1 hour because I expect to do both together. Okay, so I will pose some questions so that you relax for some points and then have some time for yourself to think. So advanced respiratory diseases like COPD versus lung cancer. So there's no difference in symptoms experienced by either patient group. Patients with COPD were more likely to be troubled by dyspnea actually than the lung. Patients with lung cancer to have a wide access to support systems because they are recognized as palliative. Patients with COPD scored significantly worse for activities of daily physical, emotional, social function. Because COPD, they are really desperate. They don't actually understand why they can't do any activities, why they are so disabled. Unlike cancer, where there's an explanation. Okay, so there's a less likelihood to have accepted their illness. Therefore, they are more likely to be depressed. So there's a marked discrepancy in access to support services. COPD, they're sort of neglected population of patients. So similar proportion of patients wanted comfort-based care and did not want ventilation. Both parties, cancer or COPD, similar proportion wanted comfort care. But most COPD patients received ventilation. 25 of those ventilators survived till discharge. But then they come back and then they die. So median 2-month and 6-month survival rates were higher in COPD. So there's another case now for time for yourself. Read. Okay, case 2, a 72-year-old patient was diagnosed to have COPD for 3 years. It's not over for 3 years, okay? Recently noted bilateral ankle edema with shortness of breath even when trying to dress himself up. So shortness of breath is severe. He had 2 recent hospital exacerbations. Admission with infected. He is very tired. Sorry for the spelling mistakes. Tired and developed panic attacks at home, which drive him to emergency department several times. He refuses food and has poor interest to talk to others. Basically isolated at home. On examination, he's dyspneic at rest. He uses accessory muscles to breathe. He had mild pallor and ankle edema. Okay, now this patient, would you call palliative?
Yes. Yes.
Yes. Some reasons. Sorry?
She's a patient with COPD for 3 years.
That is not an indicator. Duration, as to my knowledge. COPD can go on for years and years, no?
Exacerbation is having.
But patient is having exacerbations. 2 recent hospital admissions. But this 3 years has resulted in something. Bilateral ankle edema. And shortness of breath even when trying to dress himself up. Now, that is an indicator, isn't it? Probably copulmonale. Right heart failure. And then seems to have become depressed, no? And he uses accessory muscles to breathe. And also some anemia. So all these factors, let's see when we go through. Okay, now let's see. Prognostic markers. FEV1 less than 30%. Probably the patient would be classified as FEV1 less than 30% because of so much of breathing effort, accessory muscles, short of breath even at rest. Low BMI. Yes, weight loss of weight. Low partial pressure of oxygen. So we have to do the saturation. Decrease in functional status. Increase in dependence on ADL. More than 1 urgent admission in 1 year. Multiple comorbidities. Elderly, depression being single. So these, most of these factors are there with our patient, isn't it? If you go back. Right? So is palliative. So I will not go through this as a management strategy, the breathing, thinking, functioning model, because the respiratory physician will be teaching you on this. This is just an introduction into that. The management is very important to improve breathing techniques, thinking patterns, and the function. And the dyspnea ladder in the management. Starting from step 1, optimize the bronchodilators in COPD. Example, short and long acting plus exercise training, pulmonary rehabilitation, plus or minus supplemental oxygen, according to COPD guidelines. Even if dyspnea is persisting after that, non-pharmacological measures, example, pulmonary rehabilitation, pursed lip breathing, handheld fans, relaxation techniques, paced activities. So the breathing, thinking, functioning cycle, enhancing that, and then improving the quality of life of these people by proper pulmonary rehabilitation. Then even if it is persisting, then you are going for palliative pharmacological measures, example, morphine dose titration and anxiolytics. And then these are, agreeing on acceptable level of dyspnea. So you may never get rid of the dyspnea. You can't eliminate dyspnea, these people, but then they will continue. But make them comfortable with these measures, like improving the breathing, thinking patterns, and improving their functioning, and giving them appropriate morphine doses to reduce the awareness of breathing. Okay. Let's talk a few facts about the end-stage kidney disease. So prognosis for stage 5 chronic disease is worse than for many patients with cancer. You know that end-stage kidney disease, it's another form of neglected disease. Okay. So epidemiological data show that dialysis population has become increasingly elderly. So we are seeing also elderly people, not only the kidney disease of unknown origin that is found in the Polonnaru area, but people with hypertension, diabetes are also ending up with end-stage kidney disease due to age. So shortened mortality as a result of end-stage renal failure and high symptom burden from comorbid conditions. So they can have other diseases as well. hypertension, diabetes, stroke, cardiovascular problems. So patients likely to benefit palliative care are patients who have declining renal replacement therapy, who are on renal replacement therapy, but who are deteriorating. In spite of having dialysis, they are deteriorating. Currently on dialysis also means they are palliative. Then particularly people who have decided to discontinue dialysis, like the patient that I described, and people who are medically not suitable for renal replacement therapy, and elderly patients with chronic kidney disease. So symptoms with chronic kidney disease like pain, bone pain arising from second hyperparathyroidism, most commonly caused by adynamic bone disease, bone and joint pain, with both at rest and with exertion. So you have limitations in treatment of these pains. Paracetamol, yes, you can give, but non-steroidal, you have to use with caution. Things like codeine, better to avoid. Okay, tramadol, yes, but you have to limit the maximum dose. Then fentanyl, yes, you can. Morphine, advised to avoid, but if fentanyl is not available, you can go for a very low dose of morphine in end-stage kidney disease. So there are limitations in treating these patients with end-stage kidney disease as well. So they also have dyspnea due to fluid overload, due to anemia, pulmonary embolism, metabolic acidosis, fatigue, and infections. So treatment of dyspnea in end-stage kidney disease, optimizing the diuretic treatment, treatment of associated infections, giving them opioids, so morphine, especially caution when the EGFR less than 30, and other option is fentanyl and hydromorphone. We don't have that. We have fentanyl, we do have. So symptoms like pruritus due to hyperphosphatemia, giving them a phosphate binder. Due to anemia, they can have pruritus, maintain the parathyroid hormone levels with normal limits. Other treatments like topical emollients, oral anti, symptomatic treatment, ondansetron, gabapentin, then SSRIs like the paroxetine, sertraline can be offered. They have sleep disturbances, especially in the dialysis patients, maybe related to bone pain and other problems. So avoidance of caffeinated beverages to promote sleep, avoid daytime naps, exercise. And end-stage kidney disease patients who discontinue dialysis, patients live a mean of 8 days after stopping that. This is one example that I gave you in that patient whom we decided not to dialyze. Symptoms include pain and agitation, benefit from provision of palliative care. So there was another patient to tell you a story. There was one patient who was on dialysis, and this patient had several sons. One son was in USA, who was supposed to finish an exam and then come to Sri Lanka. So this person initially said, I want to continue the dialysis because I want to see my son coming back after the exam to the country. So then we arranged everything, the goals of care we addressed the pain and other symptoms and the emotional aspect, the spiritual means, and then there was some unfinished businesses the person had. We supported everything. And then this person again came back. The person had fit due to uremia, and then also had some GI bleeds. So then this person further deteriorated. And at that point, the person came back to us and said, Doctor, I think it has come to a point where I don't need any dialysis anymore. So then we asked about, okay, you said you wanted to wait till your son comes and then finishes the exam. Then she said, no, I have given up all those expectations and I've done my unfinished businesses. I've arranged all my finances. and my last will, everything has been done now. And now I don't want to live anymore in this agony and in this suffering anymore. I have decided that you can stop the dialysis and I want to die peacefully. So she wanted us to keep her, full of as much as possible pain free and free of symptoms. Okay. So then, but the family came to us and said the husband and the other son who was in the country came and said, no, now don't do this. We want you to continue the dialysis. This is not proper. Now, if this happens, she's going to suffer. We are all willing, and this other son is also coming. We want her to live some more. Please don't do this. And they said. Then, okay, so what do we do? I will ask you. Some answers from you.
Patient side.
Huh?
To take patient side.
Actually, the patient's wishes have to be respected because the patient is having good capacity. The patient can understand the information, retain the information, and then can convey the information. So the patient can weigh the pros and cons of the decision and convey the decision to me. So there is capacity. So I can decide that the patient has capacity, and I do in the best interest of the patient. I decided with patient respecting patient autonomy that to go ahead with the patient's wishes. So we manage the patient with I address the pain, agitation, and provided the care until death. So there are advanced neurological diseases like motor neuron diseases, Huntington disease, Parkinson, and all that. Okay, in all of these there are symptoms. Okay, so dyspnea, similar to other diseases, we have to manage dyspnea in these patients, and then treat the cause. If the patient is in delirium, okay, it's very important to identify the precipitating factor, not just to tie the patient or just to give them neuroleptic drugs. What you need, not to give antipsychotics only, but you have to find out the cause and address the cause. There are lots of precipitating causes. It could be drugs, it could be infections, it could be metabolic problems. So you go through all the precipitating factors and find out and treat it. Okay. So the treatment, initially you only give stat doses to calm down the patient. Remember, physical restraints avoid. Do not tie the patient. It is better to pharmacologically restrain the patient rather than physically restrain a patient. Okay. So you can give a high dose of risperidone and calm him down rather than tying him onto the bed. So you can give these other options that you can offer: oral quetiapine or olanzapine, or IV haloperidol, IM haloperidol, subcutaneous haloperidol, or risperidone orally can be given. Another aspect is dementia. Patients with end-stage dementia were compared against patients with cancer. Okay. Retrospectively with carers who knew most about disease last years of life. So the commonly reported symptoms: dementia versus cancer, mental confusion, urinary incontinence, pain, low mood, constipation, loss of appetite. All of these were actually more in dementia patients than in cancer. So the patient challenges are diminishing mental capacity, loss of personhood, nutritional deficits, and the family care, decision making, emotional support, grief and bereavement support. So all of these have to be met. These are unmet needs in dementia. The challenges are neurocognitive challenges, patient can't understand, pain, management of pain, functional problems, nutrition, and during the last days of life, what to do. So how to identify pain in a patient with dementia? Okay, agitation could be one feature. May appear tachypneic, and the facial cues, moaning and groaning. the sounds, moaning and groaning, facial cues like facial grimacing, posturing of the body there, make their bodies rigid. So only the caregiver can understand more than the doctor the fact that the person is in pain, because the caregiver is the best person who has always been with the patient, identifies when the patient is in pain, because the patient cannot come back at the patient cannot tell you. They are called silent sufferers, patients with dementia. So in that case, when you think that the person is having pain, give a trial of analgesia. So other one, this like the tools like the pain assessment in advanced dementia. So you can use of one of these tools. Okay. So the breathing, the pattern, the vocalization, facial expression, body language, consolability, they can be used. These are guides. So depression in advanced dementia, another factor. You may not detect that. So anxiety about illness, fears about being a burden, abandonment and isolation, loss of dignity and personal, and the dying process. So we need advanced care planning. Should be initiated and guided by physicians. So avoid unnecessary intervention. That's what I told you. Avoid these unnecessary peg tubing and NGTube if you have an advanced care plan. Stress therapeutic possibility to prevent the patient from suffering. What not to do rather than what to do. Okay. Give information where families can turn up for help. So in conclusion, palliative care and its resources should be extended to patients with non-cancer life-threatening illnesses suffering from life-limiting health problems. Unpredictability of illness trajectory is not a deterrent into entering a discussion about advanced care planning.